Did you know that one of the most common pre-surgery tests performed on older adults in this country has been proven through rigorous randomized clinical trials to provide no meaningful benefit at all? And yet most seniors undergoing this exact procedure still receive it anyway, every single year? We're talking about routine preoperative testing before cataract surgery, blood work, an EKG, sometimes even a chest X-ray, ordered automatically before one of the most common procedures performed on older adults in the entire country. Researchers studying this exact issue found such strong, consistent evidence that this testing provides no benefit that the American Academy of Ophthalmology specifically named eliminating routine pre-op testing for cataract surgery as the single most important issue patients and physicians should question as part of a national campaign called Choosing Wisely. And yet, despite over a decade of this clear, repeatedly confirmed evidence, most seniors having cataract surgery are still receiving this unnecessary testing today. This isn't an isolated example either. Healthcare researchers estimate that up to 30% of all medical tests, treatments, and procedures performed in this country may be unnecessary, adding up to over $100 billion in costs annually, without providing meaningful benefit to the patients receiving them. For seniors specifically, this isn't just about wasted money. Unnecessary testing carries its own real risks. False positives leading to unnecessary follow-up procedures, incidental findings that trigger anxiety, and further testing for issues that would likely never have caused a problem. And in some cases, direct physical risk from the testing itself. Today, we're going through exactly why this specific cataract pre-testing example became such a clear case study in unnecessary care. Several other commonly over-ordered tests and screenings in older adults, why this pattern persists despite the clear evidence, and the specific questions that can help you and your doctor make a genuinely informed decision together. Let's get into it. Let's dig into this specific example in detail, because it illustrates something important about how unnecessary testing happens in the first place. Cataract surgery is one of the safest, most routinely performed procedures in modern medicine, and it's the single most common medical procedure performed on Medicare beneficiaries, with researchers projecting over 4 million procedures annually within the next several years. For decades, it became standard practice for patients to receive a full battery of preoperative testing before this procedure: blood work, an electrocardiogram, sometimes a chest X-ray, following the same general pattern used before more invasive surgeries. But cataract surgery is different from most other procedures in an important way. It's typically performed under local anesthesia, with the patient awake and the surgical risk to the rest of the body being genuinely minimal, compared to procedures requiring general anesthesia or more significant physical intervention. Recognizing this, researchers ran large, rigorous, randomized controlled trials specifically comparing outcomes between patients who received routine pre-op testing and those who didn't. Multiple separate studies, conducted years apart, all reached the same conclusion. Routine preoperative testing provided no meaningful reduction in surgical complications for cataract surgery specifically. Despite this remarkably consistent evidence, research tracking actual practice patterns has found that most seniors undergoing cataract surgery continue to receive this unnecessary testing, with a meaningful percentage even receiving non-indicated cardiac stress tests beyond the basic blood work and EKG. This gap between what the strongest available evidence supports and what actually happens in routine practice is exactly why some health systems have begun specifically redesigning how these tests get ordered in electronic medical records, using behavioral nudges to reduce automatic, unnecessary ordering. It's worth understanding why this pattern persists despite such clear evidence, because the answer isn't a simple story about careless or uninformed doctors. Research specifically interviewing primary care physicians about why they continue certain testing patterns, even against established geriatric guidelines, found several consistent explanations. Many physicians genuinely overestimated the potential benefits of a given test while underemphasizing its potential harms, not from a lack of awareness, but from years of training and practice patterns built around a more testing-heavy default. Others described a real reluctance to change course when a patient appeared to be doing well under their current approach, even when guidelines suggested a different path. And many physicians described deferring to perceived patient preferences and expectations, especially when patients themselves expected or specifically requested certain testing, based on past experience, or simply a long-held belief that more testing automatically meant better, more thorough care. This last point matters enormously because it means patients themselves are often an active part of this pattern, completely unintentionally. Many older adults grew up in an era where comprehensive testing was widely seen as the gold standard of careful medicine, and that belief, while completely understandable, doesn't always align with what current rigorous research has actually found about which tests genuinely change outcomes for a given situation. There's also a structural factor worth naming directly. Ordering routine, low-value tests as part of an established protocol is often simply easier and faster in the moment than having an individualized conversation about whether a specific test is genuinely needed for a specific patient. A conversation that takes real time in an already busy appointment schedule. Beyond cataract surgery pre-testing, several other categories of testing have been specifically flagged by geriatric medicine organizations as frequently low value for many older adults, depending on individual health status and life expectancy. Cancer screening in adults with limited life expectancy is one of the more nuanced examples on this list. Geriatric medical organizations have specifically cautioned against routine breast, colorectal, prostate, or lung cancer screening in older adults without first considering individual life expectancy and the documented risks of overdiagnosis and overtreatment. This doesn't mean cancer screening becomes universally inappropriate at a certain age. It means the calculation genuinely changes for some patients, since a cancer that grows slowly enough to never cause symptoms during someone's remaining lifetime can still trigger biopsies, surgery, or radiation treatment if discovered through screening. Treatments that carry their own real risks, including the specific possibility of urinary, sexual, or bowel complications associated with prostate cancer treatment, as one well-documented example. Routine annual electrocardiograms in low-risk, asymptomatic patients have also been specifically identified as a low-value practice by multiple Choosing Wisely campaigns internationally. Since this kind of routine, repeated testing in patients without symptoms or significant new risk factors rarely changes clinical management in a meaningful way. Imaging for uncomplicated low back pain, particularly within the first several weeks of symptoms and without specific warning signs present, has been repeatedly flagged as overused, since most uncomplicated back pain improves on its own, regardless of what imaging shows. While imaging itself can reveal incidental, often harmless findings that nonetheless trigger anxiety and further unnecessary intervention. Repeated excessive blood work and vitamin testing beyond what's clinically indicated for a specific concern has also been specifically named in recent consumer health reporting on senior over-testing, often performed as part of routine annual visits without a clear, individualized reason driving the specific panel being ordered. Let's talk specifically about why this matters so much, beyond simply being wasteful in an abstract sense. The financial cost is real and direct. Unnecessary testing contributes meaningfully to the more than $100 billion spent annually in this country on low-value care. Costs that, depending on insurance coverage, copay structures, and deductibles, can translate directly into significant out-of-pocket expenses for the patients receiving this testing, on top of the broader cost to the overall healthcare system. But the medical cost may matter even more, and it's less commonly discussed. Unnecessary testing can trigger what researchers call a cascade of intervention, an incidental finding on a scan or test that was never clinically indicated in the first place leads to a follow-up test to investigate it, which might lead to a biopsy or procedure to further investigate that finding, which carries its own risk of complications, all stemming from a test that may never have needed to happen at all. Geriatric medicine organizations have specifically warned that unnecessary screening, particularly cancer screening in adults with limited life expectancy, can lead directly to overtreatment and serious health complications that wouldn't have otherwise occurred. There's also a psychological cost worth naming directly: the anxiety and stress of being told you have an abnormal finding, even when that finding is later determined to be harmless or clinically insignificant, is a genuinely real burden that shouldn't be dismissed simply because it doesn't show up on a hospital bill. None of this means you should refuse testing your doctor recommends or assume every test suggested to you is unnecessary. It means engaging in what's often called shared decision-making, a genuine two-way conversation about whether a specific test makes sense for your specific situation. Here are the specific questions worth bringing into that conversation, drawn directly from patient guidance developed by the Choosing Wisely campaign itself. Do I really need this test? This simple, direct question opens the door for your doctor to explain their specific reasoning, rather than testing proceeding as an unquestioned default. What will we actually do with the results? This question gets at something crucial. If a test result wouldn't meaningfully change your treatment plan either way, that's an important signal that the test itself may not be adding real value to your specific care. What are the risks of this test, and what are the risks of skipping it? Every test carries some risk, even if it's a small one, and understanding that risk alongside the potential benefit allows for a genuinely informed decision, rather than treating testing as automatically risk-free. Are there simpler or safer options that could give us similar information? Sometimes a less invasive or less expensive approach can provide comparable clinical value, and it's worth specifically asking whether one exists for your situation, and specifically before a scheduled surgery or procedure. Is this preoperative testing specifically indicated for this procedure and for someone with my health profile, or is it more of a routine standard protocol? As we saw with the cataract surgery example, this single question can sometimes reveal that a recommended test is more about established habit than individualized necessity. Importantly, none of these questions are about refusing care or being a difficult patient. Patient advocacy organizations and physicians involved in the Choosing Wisely campaign have specifically framed these as collaborative, informed conversations, not confrontational ones. Most doctors genuinely welcome these questions, since they open the door to exactly the kind of individualized care decision-making that current best practices increasingly emphasize. Let's bring this together. Routine preoperative testing before cataract surgery stands as one of the clearest, most rigorously documented examples of low-value medical testing in this country, supported by multiple randomized controlled trials. And yet it continues to be widely performed, despite over a decade of consistent evidence against it. This pattern persists not because of careless medicine, but because of a complex mix of established habits, time pressure, overestimated benefits, underemphasized harms, and genuine deference to patient expectations built up over decades of a more testing-heavy medical culture. Beyond this specific example, cancer screening without considering life expectancy, routine annual EKGs in low-risk patients, imaging for uncomplicated back pain, and excessive routine blood work have all been specifically flagged by geriatric medicine organizations as frequently low-value testing patterns in older adults. And the single most useful tool available to you isn't avoiding all testing. It's bringing a handful of simple, direct questions into your next appointment, opening a genuine, collaborative conversation about whether a specific test will actually change your care, rather than simply following a default protocol. Here's your action step for today. The next time a test is recommended, especially before a routine or low-risk procedure, ask your doctor directly, "What will we do differently based on the results of this test?" That single question opens a genuinely useful conversation, and it costs you nothing to ask. If this video helped you feel more empowered in your own healthcare decisions, subscribe to this channel. We cover exactly this kind of practical, research-backed health information every single week. And if there's a topic you'd like us to explore next, leave it in the comments below. We read every single one. Before you go, one more time, clearly, this video is for educational and informational purposes only. It is not medical advice, and it does not replace a conversation with your doctor. Decisions about which tests are appropriate for you depend entirely on your individual health history, current symptoms, and specific medical situation, and should always be made collaboratively with your own healthcare provider. Never decline a test your doctor recommends without first having a direct conversation about their specific reasoning for your situation. Take care of yourselves, ask those questions, and we'll see you in the next one.